Okay, so
David, yes.
thank you very much indeed for the invitation. It's a real pleasure to be with you, at least virtually. I'm really sorry I could not be with you in person for many other reasons. So these are my disclosures. So the topic is large vessel vasculitis. The main two areas here are giant cell arthritis and Tachyassus arthritis. I don't have time to talk about idiopathic aortitis. That's a different topic. So GCA and Tachyassus will be the focus. So GCA is the commonest primary vasculitis in adults. Both diseases, GCA and Tachyassus, consist of granulomatous inflammation of the vessel wall. There is a maladaptive immune response, resulting in intimal hyperplasia, adventitial thickening, and intramural vascularization, leading to vascular stenosis and occlusion. So there is, you're probably aware, there's a slight change in the nomenclature for large vessel vasculitis. So there's cranial GCA, which is our old term was temporal arthritis, so patients presenting with scalp tenderness and jaw claudication. Then we have large vessel vasculitis, GCA, and with or without cranial involvement. So we have certainly seen there are patients with cranial involvement and also large vessel disease. And then, of course, Tachyassus arthritis. And there's a very nice review here that I'd strongly recommend by Pugh and colleagues. So how do we achieve good clinical outcomes in both these large vessel vasculitides? So early diagnosis is really, really important. There's often a prolonged delay before diagnosis is made, especially in large vessel GCA, when there's minimal cranial involvement. So these patients present with non-specific symptoms, inflammation, weight loss, and fevers, and that leads to a delay in diagnosis. If it's straightforward, obviously most rheumatologists can manage patients with GCA and Tachyassus, but there should be a low threshold for specialist referral to specialist centers that deal with difficult vasculitis. And I think early treatment goes without saying. The challenges in managing large vessel vasculitis, however, are disease relapse. About a third to three quarters of patients will relapse on steroid taper or discontinuation of steroids. Chronic vascular complications are rising, so we're now recognizing that accelerated atherosclerosis can be a late manifestation of both these diseases. And trying to accurately monitor disease is a major challenge, both clinically and radiologically, and acute phase markers. Treatment, corticosteroids is the first-line treatment, but we all know the terrible adverse effects that are associated with corticosteroids. Immunosuppressive therapies I'll touch on, and biologic agents. So we're all very familiar with the clinical features of GCA and Tachyassus. Polymyalgia rheumatica may occur in up to 50 or 60% of patients with GCA. Elevated acute phase markers are usual, but not guaranteed. And then the specific symptoms and signs we're all very familiar with: headache, visual loss, temporal artery and scalp tenderness, claudication of the jaw and tongue, limb claudication, and absent or asymmetrical pulses, and the appearance of bruits. Aortic arch syndrome, well described in GCA. 15% of GCA patients will have an aortic arch syndrome affecting the subclavian, axillary, and proximal brachial arteries. The images show a patient of mine with GCA who presented with a large dissection requiring a stent. So what about GCA and imaging? PET scanning is emerging as a useful tool, but I think it is now recognized that temporal artery ultrasound in skilled hands is increasingly being used. Indeed, EULAR and BSR recommend ultrasound as the first assessment for patients with cranial GCA. And you can see here the halo sign and the compression sign, where if you press the ultrasound probe on the artery, it fails to compress and it fails to close the vascular lumen off. So these are quite useful clinical signs with the ultrasonographer. So temporal artery biopsy was the gold standard of diagnosis for GCA, but this gold standard is rather tarnished now, and it's now been overtaken by imaging. So I mentioned temporal artery ultrasound in skilled hands and other imaging modalities, which will be touched on in the next speaker. CT angiography, MR angiography, which is recommended as the first line in Tachyassus arthritis, looking at luminograms, and PET CT, looking at inflammation of the vessel, and PET MRI is emerging as well. So here's some treatment algorithms. You're all very familiar with these, starting off with a confirmed diagnosis of GCA, starting prednisolone, 40 to 60 milligrams a day, and then you reduce the steroids in a stratified way, aiming to get down to 5 milligrams a day or less by the end of the year. If there's a high risk of adverse events with steroids, then consider a steroid-sparing agent, or certainly if there's relapse or refractory disease. You can escalate steroids, but we're trying to avoid corticosteroids as much as possible because of the obvious adverse effects. If you're lucky enough to achieve sustained remission, you continue the steroid taper. Choice of glucocorticoid-sparing agents, tocilizumab, methotrexate, mycophenolate, and investigational therapies, which I will touch on. Antiplatelets are controversial. Some physicians advocate antiplatelets to reduce the risk of visual loss, and others don't because the evidence doesn't support it. And then obviously surgical and endovascular intervention, as in the patient I showed you with the aortic dissection. Confirmed diagnosis of Tachyassus, once again, corticosteroids, but the tendency here in Tachyassus is to start corticosteroids with a steroid-sparing agent. Now, my practice is usually to start methotrexate. Reduce prednisolone in a stratified way, and if there's relapse or refractory disease, you can escalate steroids or consider alternative glucocorticoid-sparing agents. The aim is to achieve sustained remission and taper the steroids. Other agents, tocilizumab, methotrexate, anti-TNFs, mycophenolate, and investigational therapies. And likewise, antiplatelet agents and surgical interventions may be indicated. There is a tendency to provide antiplatelet agents more with Tachyassus than with GCA, but the evidence base is not strong. So we're all very familiar with tocilizumab and the Tachyactus trial, the IL-6 receptor blockade. This is a very big study published in the New England Journal of Medicine, which clearly showed benefit over steroid tapers, short and long steroid tapers. You can see there was a substantial benefit in terms of efficacy with the tocilizumab, either weekly or every other week. And you can see here that tocilizumab confirms significant advantages in terms of achieving relapse-free control of the disease. A very clear result here. This is a follow-on study from the same group. This is a single-center study of 60 patients with GCA, and they analyzed the flare rate prior to starting tocilizumab with the flare rate on tocilizumab. And you can see that prior to starting tocilizumab, there was a 72% flare rate, whereas patients on tocilizumab, only 30% of patients flared, which you could say is an improvement, but it's still not perfect. There's still a 30% flare rate on tocilizumab. You can see also that the time to flare prior to tocilizumab increased from half a year to 2 years. The annualized flare rate on tocilizumab was significantly reduced from 1.4 to 0.6 events per year. And importantly, in patients on tocilizumab, there were no new flares associated with visual loss, really quite an important outcome. So it's clear that tocilizumab is effective, has a steroid-sparing agent, and is generally well tolerated, and is certainly approved by the FDA and in Britain by NICE. What about other approaches? This is in the current issue of the Annals of Rheumatic Diseases, mavrilimumab, which is a GM-CSF receptor antagonist. This is a phase 2 randomized double-blind controlled trial involving 50 centers. And here is the scheme of the study: screening, and they included patients with new onset GCA, and also included patients with relapsing or refractory GCA. Randomized 3:2 to mavrilimumab, subcutaneously every 2 weeks, or control placebo, subcutaneous placebo. All groups received a scheduled steroid tapering regimen, both in the new onset disease and the relapsing or refractory disease. And the primary endpoint was at 26 weeks of the trial duration. So you can see that this was a positive result. You can see that there was a definite improvement in the hazard ratio when looking at mavrilimumab compared to placebo, with an advantage of 0.38 in the mavrilimumab treatment arm, and in terms of patients with sustained remission, 83% versus just under 50% of patients. This is well-tolerated medication. This is used in the treatment of rheumatoid arthritis. At least in this study, there were very few treatment-emergent adverse effects. There were no serious adverse events relating to the study drug and no serious adverse events relating to death. And the safety signal was very similar between the mavrilimumab and placebo. And in the placebo arm, there was slightly numerically more, probably due to the steroid burden. So in summary of this important phase 2 study was mavrilimumab with a 26-week steroid taper was superior to placebo with a 26-week steroid taper. There was a reduced risk of flare and patients were maintained in remission on the GM-CSF receptor antagonist arm. There was no significant safety signal. And importantly here, in comparison with tocilizumab, the acute phase reactions were not suppressed. You're all aware that tocilizumab will switch off immediately the ESR and CRP response, and this makes it very difficult to judge relapses or indeed infections. So this is an advantage, I think, for this GM-CSF receptor antagonist, that acute phase reactions are not suppressed. What about Tachyassus arthritis? Is there evidence for biologic use? So there is some evidence. This is Tachyassus, tocilizumab and Tachyassus. Again, very small study, 18 in each group. And you can see it did not reach its outcome measure, only just missed it. But if you look at the intention to treat, the per protocol analysis, there was a significant advantage of tocilizumab in Tachyassus arthritis. But the proviso is that this is a very small study, but it is promising nevertheless. So in conclusion, with tocilizumab in Tachyassus, small studies, pre-specified endpoint was not met, but the per protocol analysis was promising. What about abatacept in Tachyassus? This is a study from the USA showing, in fact, again, small study, preliminary studies, but there was no difference in the relapse rate on abatacept in Tachyassus. This is probably more useful, this study. This was a systematic review and meta-analysis involving 2 small randomized controlled trials that I've just described, together with 29 observational studies with a total of around 517 patients. So what did this study report? So what they showed was that if you look at remission, there was a 70% remission rate after tocilizumab use and a 66% remission rate with anti-TNF use. And you can see here the delta is 0.66 on this forest plot. What about relapse? So relapse is substantially reduced in this meta-analysis. Only 17% of tocilizumab patients relapsed versus 28% of anti-TNF therapy relapsed. These are not controlled trials, obviously. These are not comparisons. This is a meta-analysis. So there was a reduction in relapse rates with these agents in this meta-analysis. Steroid sparing effect. These drugs did provide significant steroid sparing, as you can see with the forest plot here, substantially below 0. So there was a significant steroid sparing effect in this meta-analysis. So in summary, biologic agents in this systematic review and meta-analysis, there are good remission rates, glucocorticoid sparing effects, improved ESRs and CRP values, obviously bearing in mind the tocilizumab arm. There was, and then importantly, I didn't mention this, but the studies did report reduced angiographic progression, which is quite an important outcome. Adverse events, probably as you'd expect, there was an increased infection rate, and there still is a residual relapse rate despite these biologic therapies in Tachyassus. So there are recently published guidelines by the ACR on ANCA vasculitis, on PAN, GCA, and Tachyassus relevant to this topic, which I don't have time to go through, but the references are there for you to have a look at. So in summary, Chairman, there are major advances in the understanding and treatment of systemic vasculitis, particularly GCA and large vessel vasculitis. There are ongoing and recently completed trials, and there are FDA-approved treatments. So my acknowledgements are to all my colleagues at Guy's and St. Thomas's Hospital and the King's Clinical Trials Unit. Thank you very much indeed for your attention.